if I'm not wrong.
Third.
Case wise. Third.
केस सेकंड है सर.
हाँ
एक
second है.
सेमिनार
First.
हुआ. हाँ, 2 सेमिनार हुए, एक केस और दूसरा ये केस है.
Welcome.
Good evening, all of you.
Good evening, sir.
Good afternoon, everyone. On behalf of NNF Gujarat, I, Dr. Prashant Aiyer, Secretary NNF Gujarat, welcome one and all to Neonatal Pathshala, a unique series in which we are having a different programs, PG case presentations, PG seminar, panel discussions, and the Kaun Banega Champion competitions. We are glad that you all are joining on time and we start on time. So I request Dr. Sandeep Trivedi to welcome the audience.
Thank you, Prashant. I welcome all the faculties and Dr. Ashish Mehta sir, social sir as a advisor, and Dr. Mohit is the in charge of the case presentation of Pathshala, and I welcome Dr. Sheila Aiyer and Dr. Sitaraman as a expert, and Dr. Shwetal Bhatt as the chairman, and also I welcome case presenter who is the Dr. Janakiram, and welcome to you all participants also. Hand over to Prashant.
Thank you, Sandeep bhai. Once again, I request everyone to like our YouTube channel and subscribe it so that you can get the regular updates. And for all further Wednesday programs, you can join by the same link. Today's chairperson for the PG case presentation is Dr. Shwetal Parikh. She is Associate Professor of Pediatrics in Baroda Medical College, and she is having a teaching experience of 22 years. She is the Secretary of AOP Gujarat Women's Wing, and she was the Secretary of NNF Gujarat 2014, 13-14 and 15-16. So I welcome Dr. Shwetal ma'am to take the proceedings. Thank you.
Thank you, Dr. Prashant. It's my pleasure to introduce both the faculties for today's case. First, I would like to introduce our guest faculty, that is Dr. S. Sitaraman sir. Sir has lot of feathers in his head, but just like to shorten the thing, he is at present he is professor at SMS Jaipur Medical College, and sir has done many pioneer, like he's been pioneer in establishing the human milk bank at SMS Jaipur. SMS Jaipur has like so many subspecialty in a full-fledged form, which I'm amazed to see, and their newborn, like a huge newborn NICU is there, where they are like day in and out, they are actually involved with the NICU care. Multiple faculties are there. In fact, the students who passed out wants to go as SR to SMS Jaipur. So that's the credit, sir. Welcome, sir. I would like to introduce my mentor. In fact, I will say as a like for 24/7 guide. That is Dr. Sheila Aiyer, ma'am. Madam is head and professor of Department of Pediatrics at Baroda Medical College, and she has also been pioneer for establishing the human milk bank and many other things. VIC, like our department has been so well equipped and one of the best neonatology center for the Gujarat. And I would like to welcome ma'am as a faculty for the case. I would like to introduce Dr. Janakiram. He is a resident from third year resident, almost exam going, like after 2 months he will be appearing in the exam for presenting the case. He has also taken up in a very short time the case. So let's, I'll hand over the rest for Sheila ma'am, and Janki can start. Janki?
Yes, ma'am.
Have you joined? Yes.
Yes, ma'am. I have joined.
You can start with your case.
Okay, ma'am. I'll start.
Before you start, Janki, just few words. As a case discussion, we earlier discussed a case of respiratory distress syndrome in our first meeting. And today we are taking another case with respiratory distress as a manifestation, but a nightmare for any pediatrician or a neonatologist looking after newborn at any level of neonatal care center, that is Meconium aspiration. So Janki can start with his presentation.
Yes. So is it visible to everyone?
Yes.
Yes, it's full screen.
So shall I start?
Yeah.
Yes.
Good evening all. I am Dr. Janakiram, third year pediatric resident from Baroda Medical College. and I'm presenting a case of severe Meconium aspiration syndrome under guidance of Dr. Shwetal ma'am, Associate Professor, Department of Pediatrics, Baroda Medical College, and Dr. Vaishali ma'am, Assistant Professor, Department of Pediatrics and Baroda Medical College, Baroda. So I'm starting the presentation. To start with, I'm starting with the name of the patient is ABC, and they are from Jagadia, Bharuch, a tribal area in Gujarat. And with the antenatal history of, it was a primigravida mother, aged 26 years and married since 3 years, and had regular antenatal checkups and booked case at CHC Raspipla. It was a nearby CHC where the mother was having regular antenatal visits, and the mother took iron and folic acid tablets regularly, and TT 2 days doses have been taken. Antenatal 3 antenatal ultrasound was done. No records were available, but the mother was told that 3 antenatal scans was normal. Coming to the natal and postnatal history, her LMP was 7/4/2021 with expected date of delivery on 14/1/2022, and the child delivered on 10/1/2022. The onset of labor was spontaneous at 39 weeks plus 3 days of gestation age, and the liquor was Meconium stain. The baby born by vaginal delivery of spontaneous labor. The birth weight was 2.5 kg, and it was a male baby which cried immediately after birth. And this baby, baby was referred from outside, we don't have the resuscitation details and the Apgar score, but as such for referral note, it was a male baby of 2.5 kg having Meconium stain liquor at birth and cried immediately after birth. No resuscitation was required. So baby was vigorous and had tachypnea distress, so shifted to NICU. As the baby was having tachypnea distress, patient was started on IV fluids, and minimal oxygen by prongs was started from the birth. And due to worsening of the respiratory distress at around 18th hour of life, patient was referred to our hospital for mechanical ventilatory support. So this is the condition on admission in our hospital. Baby was admitted in our hospital again at 18th hour of life. Baby was sent by 108 ambulance. It was provided by government, and the oxygen support was given by prongs. And on receiving the top score, child was euthermic, euglycemic with the Downey score of 8/10, and Thompson score was 3/22 of admission. And the heart rate was around 170, and the saturation was noted in all the 4 limbs, which is showing right upper limb is 90%, left upper limb is 85%, right lower and left lower limb it is 84%. So showing the pre-ductal and post-ductal difference of 6%. And we did a functional 2D echo, which was suggestive of PPHN changes. And with the Downey score of 8/10, we had intubated the patient. We had kept the patient on SAPPV mode of mechanical ventilation with 22/5 pressures, and FSAT was 50, and the FiO2 requirement of 70%, along with all the routine investigation we had sent. And initial septic screen was also sent, which was negative. And I'm showing the ABG on admission, which is showing 7.117 with the PCO2 of 75 millimeters of mercury, PO2 of 40 millimeters of mercury, bicarbonate is 22.4, and base excess is 6 millimole per liter, with the saturation on ABG is 88.1%. So the receiving ABG is suggesting of respiratory acidosis with hypoxemia secondary to, most probably secondary to the lung involvement because of Meconium stain liquor. And child was started on intravenous fluids and mildinone at minimal dose at 0.3 microgram per kg per minute. And first line antibiotics we had to start, as it was an outbound child requiring a NICU stay of 18 hours in an outside NICU. And on receiving also, child required invasive mechanical ventilatory support along with umbilical vein insertion for the provision of inotropes, because the 2D echo of suggestive, functional 2D echo, which was suggestive of PPHN changes.
Just wait, Janki. Go to previous slide and let the experts ask you the questions.
Okay, sir.
Ma'am and sir, Sheila ma'am and Sitaraman sir.
Okay, can you go to the first slide, Janvi?
Yes, ma'am.
Okay, here this was a case which was, at least for a tribal area, has received antenatal care. She's been booked. We know
Yes.
her LMP, EDD.
Yes,
She
ma'am.
has delivered spontaneously. Now you said that the baby was delivered with Meconium stained liquor. But say, for example, one was in a center where all antenatal and intranatal monitoring would take place. So what would be the preventive approach to not to have, I mean, decrease the incidence of severe meconium aspiration syndrome or this? So what is currently recommended preventive and the natal management for meconium stain amniotic fluid?
Preventive measures, we have to take regular antenatal checkups, and we have to categorize the risk, like if the mother is having PAH or any hypertensive disorders of pregnancy, or anything that causes fetal acidosis should be identified as early as possible, and the child should be referred to higher center for the further fetal well-being monitoring, so that the effective intervention can be taken at time to prevent further complications like meconium stain liquor has happened, and prevention of perinatal asphyxia could be prevented by preventing the hypoxic damage as early as possible, by prompt monitoring of fetal well-being, by identifying the fetal risk factors which could be seen in the antenatal period.
So maybe you are saying that good CTG monitoring and fetal distress should be picked up early. Is
Yes,
there
ma'am.
any role of, because we could come only to know about meconium stain liquor when there is rupture of membranes. Is there a role of amnio infusion in current day practice?
Yes, ma'am. There are studies available for the usage of amnio infusion when there is thick meconium stain liquor. The amnio infusion given could dilute the meconium contents, and that could reduce the severity of the respiratory distress that is caused by the chemical pneumonitis or mechanical block that is caused by the meconium plugs, as the amnio infusion has a role in diluting the meconium when it is being given.
But is the current meta-analysis recommending it? Here, earlier what you are saying was the recommended mode. But
Yes,
now do we recommend? Does Cochrane or anybody suggest that
No.
amnio infusion should be a battery of interventions
No,
available
no.
for meconium?
No, ma'am. Currently, it is not available.
Okay, so that's almost clear that we are not. And any disadvantages which were noted with amnio infusion?
There are chances of introducing infections inside chorioamnionitis, and procedure-related complications could be there. That again will induce many complications for the child, and that may induce again the hypoxic damage to the fetus.
Okay, as a pediatrician, if your obstetrician asked you at what gestation should they give elective, induction of labor? See, this mother went into 39 plus 3
39.
weeks. But what should be the recommended in case she didn't go for 40 weeks? Because you are aware that as the gestation progresses, the chances of meconium stained liquor increases. So
Yes,
what is the current recommendation where one would like our obstetric colleague to induce?
Less than 41 gestation weeks, we could induce labor for the fetal well-being.
Less
So
than
our
41 means you mean what?
gestation weeks, ma'am.
Means 40 plus you want to say? Or
Yes,
at,
ma'am. Hello, ma'am. Hello.
what would
ma'am, your
uh,
question was not audible.
okay, what I mean, you said less than 41.
Yes,
So
ma'am.
would you like less than 41 would mean anything between 38 to 41. So do we want to ask our colleagues to induce by 39 weeks also?
If there is signs of fetal hypoxia or acidosis, we could induce the labor if there is no other obstetric complications or fetal complication related to that. ma'am.
Okay, currently mainly it would be 40 plus, nearing 41. Then even if there was no labor which has been induced, probably they could go for induction.
Yes.
Okay. What would be, you as a pediatrician attending the call, what would be the protocol that you would use? This was an outside delivery, but as a pediatric resident, when you have gone to labor room or a C-section call,
Yes.
what are the things that you would keep in mind? Or is there any intervention that you would do?
As such, attending the birth of meconium stain liquor, first thing to be see is whether the child is vigorous or not vigorous. So if the child is vigorous and there is no signs of tachypnea distress, we'll go for the routine care like drying and suction and clearing the airways, and we'll keep the child on mother's chest for the hypothermia prevention, and we'll be planning to start the feeds and all. The child is non-vigorous or the child is having significant tachypnea distress, and requiring having barrel shaped chest or tachypnea distress with hypoxia or perinatal asphyxia, we may have to do initial resuscitation measures followed by the bag and mask or intubation, whatever is required according to the protocol, and we may have to shift the child to NICU care for the post resuscitation management and further care to be given in the NICU with proper prompt interventions like proper oxygenation, hypothermia prevention, and hypoglycemia and other stabilization
So
measures
in
to be
short,
given. at the NICU.
basically elective intubation in non-vigorous baby is also not required, depending on the need for your NRP protocol.
protocols
If
will
needed,
intubate.
you would do,
Intubate.
because current recommendation also does not require
Intubate.
elective. So rest of the yours in case, but if the baby is associated one who has a poor Apgar, does it have any implication?
Yes, ma'am.
At
Because the
5 minutes your Apgar is low, or even at 10 minutes your Apgar is low. Does
Yes.
it have any implication?
Yes, ma'am. It is actually perinatal asphyxia that will cause further hypoxemic damage, and the child going in for PPHN chances and the encephalopathy chances are more, and then we have to shift the child to NICU for further care. The hypoxic damage will be more.
Okay, so this
Along
would
with
be
this
an
MSL.
Meconium aspiration syndrome with. Acha, would you like to confirm that? One is
Yes,
poor
ma'am.
Apgar. What else would you do it at delivery or soon after delivery?
And we can send umbilical artery, assess the pH of the umbilical artery, and we can see any acidosis of pH of less than 7 or base excess is more than 14, like any other lactate more than 4, to look for the perinatal asphyxia and hypoxia related changes. At the NICU also we can do scoring systems like Thompson scoring to assess the neonatal encephalopathy, and then we can work accordingly.
Okay. Okay, one more question. That units who have therapeutic cooling with them, the child has signs of Meconium aspiration syndrome as well as fitting into criteria for therapeutic cooling. Should they do therapeutic cooling, or it would be because there are other signs of Meconium aspiration syndrome, the therapeutic cooling will not be given to them?
And therapeutic cooling, if required for moderate to severe encephalopathy, as indicated by Thompson scoring at NICU, and we may have to start the therapeutic hypothermia within 6 hours of stabilization, provided the child is hemodynamically stable and the child is not on inotropic support or major congenital anomalies has been ruled out.
Okay, go ahead. Dr. Sitaraman, if you want to, in the initial neonatal, something want to ask.
Just 2 points in history I would like to ask. First of all, you have not made a mention about the presentation of the child. What type of presentation was it?
It was a vertex presentation, sir. Cephalic presentation.
Yeah. Whether it's a vortex or breach, one has to make a note of that also, because you are likely. Yeah.
To get the perinatal asphyxia.
Yeah. And secondly, you have mentioned that PPHN is a possibility. Do you think that there may be some antenatal factors in the mother which would cause PPHN otherwise in the newborn?
Yes, sir. The antenatal history as such is not suggestive of any PAH or any eclampsia. Was not, there was no history of any long-term drug intake in
Any
mother.
drug history?
No, sir. No history of drug history, drug intake, sir.
Which drugs would you ask for?
If the child mother is having PAH, child she may be taking labetalol drug for antihypertension.
It can cause PPHN, I mean.
Sir?
What
Which
drugs will
other
you
drug can cause PPHN is what sir is asking you.
Drugs causing PPHN.
Yeah. Anything?
Fine, if it doesn't strike you, say no.
Sir, I'm not remembering the answer.
You're not aware of any particular drug which can cause PPH in a newborn? Like if the mother is on SSRIs?
Yes, sir.
Yeah?
Yes, sir.
They are likely to have these issues coming up. Yeah?
Yes.
Yeah,
Yes.
so it's an important part in the history that we should include, because
Because
what was the
that will be-
medication mother was receiving.
Yeah. Okay. And do you think that a Meconium aspiration would have be predisposed to infection, or the infection predisposes to Meconium aspiration?
Sir, as such, the meconium aspiration, meconium itself is bacteriostatic that can cause infection in the lung, and it contains some bacteria also, so it can cause. The thing is initially antenatal if there is a.
Just hold on. This meconium has got bacteria?
No, sir, it inhibits the bacteriostatic growth of amniotic fluid, bacteriostatic activity of amniotic fluid.
How?
Mechanism, I don't know, sir, actually.
Yeah? Does the meconium predispose the lung to infections?
Because this has been debated a lot. That's why this question, Janki.
Maybe secondary to airway damage or provoking inflammatory cascade and complement activation, it can cause secondary infection.
Polymorpho burst can be avoided by this. It inhibits that. Apart from that, it can predispose to E. coli infection also.
Yes. Okay.
Okay, go ahead.
Okay, there was one more drug added, which was aspirin. If mother is being taking it,
Yes.
it could also at times lead to PBHN.
Okay, sir. Shall I go ahead, sir?
Yes. Okay, this was a case which got admitted to us because had already respiratory distress.
Yes.
But after you had attended a call in the labor room and there was a meconium stained amniotic fluid, baby was managed for resuscitation as per protocol. And otherwise didn't, how long would you monitor them? And how would you decide that this is mild, moderate or severe?
And clinically,
the patient was resuscitated by you, and now you have brought the child inside. Now your neonatal management, as you said, has started with TABC. You are keeping the child under monitoring.
So clinical grading of meconium aspiration syndrome is if the O2 requirement is less than 40% of less than 42 hours to maintain the saturation more than 90% in a child with meconium stained liquor, it is mild meconium aspiration syndrome as per clinical criteria. And moderate will be more than 48 hours, more than 40% for more than 48 hours of O2 requirement. Severe is any meconium baby with meconium aspiration syndrome requiring mechanical ventilatory support at birth and requiring FiO2 requirement of more than 40. So accordingly, we can classify the meconium aspiration syndrome severity.
But when would you, what are the classical, this required to call somebody as this is MAS and not
Yes,
the other
postnatal,
DD?
postnatally, the card will be meconium stained in meconium stained liquor. That shows the child is exposed to meconium for at least a minimum of 6 hours. And there will be barrel shaped chest and hyperventilation on X-ray and atelectasis on X-ray and pneumothorax pack could be there in X-ray, and then areas of atelectasis with air bronchogram and some areas of hyperinflation. As such, the meconium aspiration syndrome X-ray features suggestive of uneven lung disease, ma'am.
Okay.
And clinically also, if
the
there is
differential diagnosis that though you know that this is meconium stained liquor, baby required some resuscitation, you are brought to the NICU. Is there any differential diagnosis that you would keep in mind?
Respiratory distress as such, it could be secondary due to transient tachypnea of newborn. No? And
in which cases would you think that as transient tachypnea of newborn?
In late preterm or late preterm cases or mother with the history of gestational diabetes mellitus where the lung.
Okay. Anything else?
X-ray features will be suggestive of your fluid in the transverse fissure.
No.
Okay.
Or sunburst appearance according secondary to.
With the mode of delivery, does it have any influence?
Sir?
Mode of delivery.
Yes, sir. The normal delivery process as the lung fluids can be secreted outside as when the child is delivered by normal delivery, which may not be possible in cesarean section. So if the child is born secondary to cesarean section, the chances of TTN will be more.
Okay. So basically a late preterm C-section and your radiological picture not very well fitting into an MAS,
Yes.
but more like TTN, you will have to, though born out of meconium stained liquor, you
Yes.
might have to put as that as a differential
Yes.
diagnosis.
Yes.
For
Go
the
ahead.
pigmentation.
Yeah, what else would you see? You said umbilical cord staining. Anywhere else? Which
Sign-
suggests that this could be a prolonged staining of meconium, or the child has passed for a long time the meconium in utero.
Signs of post maturity we can look for, ma'am.
Okay, so that would suggest again a placental dysfunction and a
Placental dysfunction.
prolonged maturity. But sir is asking staining. You said only cord.
Staining of Vernix caseosa also we can see, ma'am. That shows the child was exposed to meconium inside the uterus for more than 12 to 14 hours.
So nail and vernix caseosa
Vernix
are
caseosa.
important parts that you have to look at when you look at the stain.
Yes.
Okay. But if you have a child which comes out and you're trying to revive and you find the chest is barrel shaped,
Sir.
would you have other possibilities you would like to rule out just dumping on the diagnosis of Meconium aspiration? So only Meconium aspiration you directly, you know that the child has shown that there was a Meconium stain liquor,
Yes, sir.
but when the child is trying to be revived, he finds that the child has a barrel chest. And then would you like to have other differential diagnosis?
Barrel chest assets. Maybe
And he is in
CDH.
respiratory distress, obviously. He is not responding to your therapy also.
Yeah, so what's another common that we have to rule out as differential diagnosis?
Pulmonary hypoplasia or CDH, congenital
Okay, so
diaphragmatic-
congenital malformation, anything else? But the baby has distress, baby is cynosed.
Okay, I'll give you a hint. He has been vigorously revived.
pneumothorax could be a possibility, sir.
Good. You should rule it out always.
Yes, sir.
Because in a meconium stain, the incidence of air leak, especially pneumothorax, is very high.
Improves.
And the last would be your cyanotic CHD.
CHD.
That also does remain, though you have meconium as this. Okay.
Okay, go ahead.
And showing the course during NICU stay. I have shown the ABG picture on receiving with preductal and postductal SpO2 difference. And with that ABG finding, the child was having respiratory acidosis, requiring mechanical ventilatory support as at birth. With clinically, we have classified the child as having severe meconium aspiration syndrome, and functional 2D echo was suggestive of PPHN changes. So we have started on Mildrinone, and then with mechanical ventilatory support at 24th hour of life, surfactant was given, Curosurf was given, and then we had gradually reduced the pressure support to 20/5, and FiO2 also we were able to come down under SpO2 monitoring. And I'm showing the pre-surfactant and post-surfactant X-rays here. The left-sided one is pre-surfactant X-rays showing fluffy opacities all over the lung fields. And with this child was given surfactant, and then the post-surfactant X-ray that was taken after 6 hours, showing some improvement in the aeration, and there is some pneumothorax packets, or also we can see in the left lower lobe. So with that changes, we had come down on pressures also to prevent further complications of pulmonary air leaks. And with surfactant, the lung condition has been improved, and we were able to come down on SpO2 requirements under gradual SpO2 monitoring.
So in such a case, when do you actually suspect that the PPHN would have taken place?
And initial the PPHN on receiving, there will be severe tachypnea distress, and the change preductal and postductal SpO2 monitor we have to take, and we have to see look for the difference in preductal and postductal changes. Labile hypoxemia will be there, like the SpO2
That's
will
already
be
there.
Sir?
That's already there because of the Meconium aspiration.
Yes, sir. Labile hypoxemia is suggestive of PPHN, sir.
What sir wants to know, how do you, I mean, when would have it happened it, as well as what are the mechanisms causing PPHN?
Yes, sir. The PPHN secondary to meconium aspiration syndrome is either caused by the lung VQ mismatch most commonly, caused by partial or complete airway obstruction causing VQ mismatch. And secondary, it could be secondary due to chemical pneumonitis caused by the meconium itself. And third mechanism is pneumothorax, and then inflammatory cascade that is initiated by chemical pneumonitis. Could anything, so these are all four mechanisms causing hypoxia and acidosis. Secondary lead to pulmonary vasoconstriction and then PPH in Meconium aspiration syndrome. Sir.
Oh, would you have done this differently if the child had been inborn?
Inborn child. Yes, sir.
Yeah. Would there have been any difference in how you would handle if it had come to you as and you attended it?
The inborn, if the child is vigorous, we'll be taking routine care will be given. If the child is not vigorous or having tachypnea distress, we'll take the child to NSU. We'll maintain TABC, temperature, airway, breathing, circulation will be maintained to provide euthermia. Sugars will be taken care of to look for hypoglycemia. If it is there, we have to correct it. And fluid status, we have to ensure. And then SpO2 to be maintained above 90% according to the clinical status of the baby by O2 by prongs or CPAP or mechanical ventilation support as early as possible. And then we can identify the PPH and related changes also as early as possible if the child is inborn. And surfactant was also the child we had received at 18th hour of life. And if the child is inborn and requiring this much mechanical ventilatory support, before that we could go for early surfactant administration to prevent further complications. Sir.
So
What about the initial TPS resuscitation? Would you like to use a TPS after you have intubated the baby, cleared it up? Do you require anything like that?
TPS resuscitation.
What? You have done that? No.
Sir, it could we could require a TPS resuscitator to push the fluid out of the.
What's the advantage compared to a routine ambu bag? If I use a TPS resuscitator, what is the advantage?
The blended oxygen supply will be there, so we can use.
Other than that,
oxygen.
in the pressures, what do you get as advantage?
We can monitor the pressure required.
That is what else are you giving as compared to your ambu bag when you use a TPS?
Especially in these cases.
Yes, this or even your preterms. Why do we use their TPS resuscitator?
To provide PEEP to prevent lung collapse, alveoli collapse that could prevent hypoxic damage and secondary PPH.
Okay.
Okay.
Go ahead.
I am continuing with the course during NICU stay, and at 36th hour of life, patient still on mechanical ventilatory support, and gradually under heart rate and SpO2 vitals monitoring, we had come down to from on ventilatory pressure on 18/5 with 45 Fset and 40% FiO2. At this time, where the vitals were for 165 heart rate, SpO2 96% and 96.5% on pre-ductal and post-ductal, with the NIBP of 64, 3/34 and 42, and CFT was prolonged 3 seconds. So we had called for urgent bedside 2D echo, which was done by a cardiologist, and thus suggestive of PPHN with ventricular dysfunction. So with ventricular dysfunction, along with intravenous fluids and injection milrinone, we had to start on inotropic support, minimal low dose adrenaline to support the cardiac function as the child was having signs of shock. Clinically, CFT equal to 3 seconds with low NIBP, along with bedside 2D echo suggestive of right side ventricular dysfunction. Along with proper fluid therapy, we had started on low dose adrenaline. And we had sent MISN investigations as there was ventricular dysfunction, which was suggested by the cardiologist. And I'm showing the MISN investigations and ABG parameters at the time of ventricular dysfunction. The spike antibody is 4.59, total antibody is 430. With ferritin of markers I'm reading, ferritin of 440 nanogram per ml, the cutoff being less than 260 nanogram for a full-term neonate, and D dimer of 1573, the cutoff being less than 200 again. LDH is 445 unit per liter, and the cutoff being less than 450 for the term neonate. Troponin I was negative, CRP was 12 microgram per deciliter, and pro BNP we were not able to get, sir. And the repeat ABG suggestive of pH of 25, PCO2 35, PO2 was improved as compared to previous, and base excess is 10 millimole per liter, and bicarbonate of 16 millimole per liter, showing the some metabolic acidosis, maybe secondary to the ventricular dysfunction. So we had started on PPHN management along with the inotropic support in this time at this juncture.
What is the cause of the shock in this?
The PPHN causing ventricular dysfunction. So the right-sided heart pressures are more, that causes the right ventricular pressure to go the suprasystemic level, and that could cause left ventricular cavity obliteration and reduced preload to the left ventricle, that could cause shock in this child.
Can which has caused meconium aspiration could shock in this child?
Sir, I'm not able to get the question. Sir.
Can any other associated condition can cause shock in the child apart from your cardiovascular?
Cardiovascular syndrome. Pneumothorax, if it is there, could cause shock in this child.
Was there any element of asphyxia in this child?
No, sir, there was no element of asphyxia in this child, sir.
Would you consider any kind of a that? No.
No, sir. There was
Probably we
no.
didn't have the cord pH, and the Apgar means child had cried immediately. We took it for, and the first ABG was more in respiratory acidosis.
Yeah.
We took it as that this baby did not have perinatal asphyxia, as well as on neurological examination didn't fit into much into any of the hypoxic ischemic encephalopathy. So that was an indirect evidence we took that probably we didn't have a significant asphyxia.
Okay.
And during this phase, we've been seeing a lot of MISN, and when especially ventricular dysfunctions were seen, we have been sending them. This child did not get treated as MISN, but we did do workup of MISN.
Shall I go?
I would ask my other colleagues to add in what have they've been seeing, because currently Gujarat, suddenly for last 1 week we have a epidemic of GBS coming up, and all of them have very high COVID antibodies.
Yes, we also noted that. In fact, in some cases there have been very remote history about COVID also, but we get a COVID antibodies and all done, and we find that thing is there.
Yeah, so
But
kind of
case, the mother did not test positive for COVID. Or
mother was not tested positive, and mother was antenatal. Mother was not having any COVID infection. Exposure was not there.
Okay.
So this many times causes dilemma. Individual decisions we make it over there over a patient, whether to be treated as MISN or just observe as well as see their clinical response.
Yeah, but according to your MISN investigation, do you feel there was anything?
Little bit of, this ferritin and D-dimer again in newborn are a very, very kind of dicey. But CRP was not very high, troponin was negative, LDH was within normal limit. So we didn't really call it that the inflammatory markers are very high. While others, we have got very high pro-BNP, very high ferritin and high CRP. So here the inflammatory markers were not very high, and the spike antibody and this were positive. We just kept it as a probability, but didn't treat with intravenous immunoglobulin or steroids. At this point, Janki, I would ask, is there a role of steroids in meconium aspiration syndrome?
Yes, ma'am, there is a role of steroids, like inhaled steroids as well as intravenous steroids, reducing the inflammatory cascade. Postnatal role of steroid is there in meconium aspiration syndrome as well as MISN.
But has it been recommended as standard of therapy?
No, ma'am, that is not.
These are still trials being conducted.
Trials being conducted for
one,
inhalational as well as IV trials have been conducted, reducing the inflammatory cascade.
Yeah.
Okay.
Shall I go ahead?
Ma'am, over here, one of the participants want to know, how do you differentiate MISN from bacterial sepsis?
Definitely that has been a dilemma, and if we get a culture proven sepsis or more favoring towards sepsis, we have been treating that as sepsis. Okay, here also the culture was sent, other markers were seen, because if we have more of cardiac dysfunction, or the coronary involvement and other things, then we have been thinking in terms of MISN, because pure sepsis would not give me those findings. The shock of sepsis would be different and not cardiac in case of shock due to sepsis, while MISN, the shock has been secondary to the cardiac function.
And even, ma'am, there was no history of leaking PV or any other maternal risk factors probing towards the bacterial sepsis.
Yeah. Here, one of the chat box question is PPHN also can cause. And here we thought that only as a more. And that's why I said we were conservative in not putting the diagnosis of MISN, though we worked on it. Okay. Because one of the, I think, chat box, this comment is that yes, PPHN also causes. And that's what I think Dr. Sitaraman asked Janki about it, and the role of asphyxia in causing cardiac dysfunction also is important, which we have to keep in mind. What is the role of surfactant, Janki, in case of meconium, and what is the current recommendation to be for each patient of meconium? Who should be given surfactant, bolus, lavage, and what is the current status of it as far as AAP recommendation, Cochrane recommendation, Canadian Society, or what would be the recommendation?
For surfactant therapy in Meconium aspiration syndrome is given as a bolus therapy in Meconium aspiration syndrome requiring severe Meconium aspiration syndrome requiring mechanical ventilatory support with the oxygenation saturation oxygenation index of 15 to 25 is preferred. 15 to 25 is coming under moderate hypoxic failure. There are studies proving that with 15 to 25, the surfactant administration has given positive outcomes in children with Meconium aspiration syndrome, and that is being given by bolus method, and the surfactant administration by lavage method is obsolete now.
But
Dr.
has it
Sitaraman,
come into
anything
a
more?
standard of practice?
Sir?
Has it come into a standard of practice, giving surfactant in all the
No, sir.
So when will you decide when to give, when not to give?
If there are X-ray changes suggestive of Meconium aspiration
So
syndrome,
that will be there in all the ways.
if the pH is less than 7.25 and any mode of mechanical ventilatory support, and the PCO2 is more of suggestive of respiratory acidosis, then we may think of giving the surfactant to improve the lung condition, sir.
And the FiO2 requirement is
FiO2
also, as you said,
requirement is also
oxygenation index and your FiO2 requirement.
Yes.
Okay.
Yeah.
So yes, primarily your lung condition and your this requirements which would make it.
Because in the conventional line of management, based on your lung condition and the FiO2 is not improving, then of course you have to tell it.
Yeah, true, sir.
But it is again because it has still not been taken as a clear recommendation. You know?
Yes, sir.
Okay. What
Go
else?
further.
I'm just showing the points favoring MISN and points against MISN in this kit. The points favoring MISN is significant elevation of total antibodies against SARS antigen, elevated D-dimer values, LDH was borderline, and ferritin was also elevated. And cause of meconium passage and fetal distress and hypoxia, whatever the cause of meconium passage inside utero, and there was not available, and there was no antenatal risk factor for MSL in this patient. So the MISN could be causing fetal distress or hypoxia, and that could cause passage of meconium in this child. And points against MISN is there is no maternal history of COVID exposure during the antenatal period. Troponin I was negative. 2D echo was suggestive of RV dysfunction, that is secondary to the lung condition causing RV dysfunction, and the coronary arteries were normal in 2D echo. And the pro-BVNP we were not able to get done.
But is it only a maternal history of no COVID-19 is sufficient to say that mother has not had exposure to COVID?
No, sir. No, sir.
What would you have done else?
Whether we can ask whether the mother was vaccinated against the COVID-19. We can ask for the vaccination status, which was not available as per the history. They haven't taken the COVID-19 vaccines.
And suppose mother had a asymptomatic variant?
that we can the elevators markers could be elevated in mother also, sir, and then we can go for RT-PCR also, which could come out.
RT-PCR would not be there. What else
TPCR
would be
cannot
there?
be at this stage. Na?
Markers
There
could
are
also
other
be
family
elevated.
members being affected. Was she exposed to COVID positive cases?
Again, the markers can be studied in mother also, so, to look for the positive exposure history.
Okay. Any antibodies all can be all checked up in that.
Checked.
Yeah. And as madam said, epidemiological diagnosis has also to be made.
Yes.
So that the family is also exposed to COVID infection.
Yes, sir.
I think one of the chat box question has been, why was MISN as a DD thought of? To tell you this, that during this post second wave and even now post third wave, we've been getting some of the cases where many times we are not exactly able to pinpoint certain things, or when we find a particularly hypofunctioning of left side of the heart with some findings and the markers are positive, we've been little more investigating. But one thing be very clear is we are not liberal with steroids and giving them IVIG, but we do many times end up investigating them. Because I think one of the question in chat box is, why even think of MISN? That's why I'm just telling it. And that's why I was asking our other experts in the group that, are you seeing something like this, or many mothers coming as positive? Some encephalopathies also we've been facing this. And that's why one of the things that we did keep in mind that we'll work up for that.
Especially we get mothers where the antenatal risk factors are not there for birth asphyxia, ma'am. And still the child ends up with severe HI, MSL and birth asphyxia. This is routinely which we are seeing since last 3-4 months, where when we worked up for MISN, they are positive, but we judiciously use our, like whether to treat or not, that criteria we have fixed up. Otherwise, unexplained birth asphyxia and MAS and with PPH and right from the birth, we are facing since last 3-4 months.
I think that is a very valid point to think, but we have still not be able to come to a conclusion.
Yes, sir.
But
Yes,
sir, yes, sir.
Yeah,
And
but
so we have to be very judicious in using the steroids, especially the dose which is higher, and the IVIG. This two, IVIG being an exclusive drug as well as expensive also, and steroids has its own risk-benefit ratio. So yeah, we are pro in diagnosing, but not so while treating. We use our own protocols for that.
Yes, Biraj, your comment, mother's antibodies, at times this all under JSSK, what is done in hospital, we do it at times, number of investigations, we do have to restrict it because all this comes with, some of them are not done, then when I do it outside, it would add to the cost. Whatever is done at the hospital laboratory, and then for COVID antibody, we were little given restriction for number of samples to be done. And as we were not very strongly going for it, the mother's antibody levels were not done. Okay.
And
Hello,
practically speaking, mother's antibody titers, if you go for
Majority are coming
we
positive.
get lot of positive without the symptomatic baby also. So they are all misleading for us just now, as there is no clear-cut guidelines or no still studies will be coming up. Otherwise, most of the population has been exposed, and the antibody titers are, even if we go for few of the mothers, they turned out to be positive.
Hello everyone, I am Dr. Vijayalakshmi from Chandigarh, from Chaitanya Hospital. Ma'am, regarding MISN, actually we are seeing a lot of babies, as ma'am has already discussed. And according to the newest guidelines, only 2 out of 6 inflammatory markers, if they are positive, along with the SARS antibody positivity, and if we're having severe cardiac dysfunction, and especially if the pro-BNP is raised, then we are going for high-dose steroid. As per the recommendations, methylpred or high-dose Dexa, and immunoglobulin, if at all indicated. Like we are seeing MISN babies with severe cardiac dysfunction, MIS baby with getting untreated and DIC, persistent coagulopathy and thrombocytopenia. So in these babies, we are preferably giving IVIG and steroid, and the babies are drastically improving.
Yeah, Bhagyalakshmi, totally agree with you. at that severe cardiac dysfunction, and our bedside echo has helped us a lot in differentiating or deciding whether to give or not. I totally agree with you, and we have kept that as an important parameter while giving it. But here,
Yes,
because
very
the
true.
child was improving and other things, and we did put it for this debate only, we said we will discuss this today while discussing the case. Otherwise, as a part of Meconium, why routinely a MISN workup? I would say no, it's not required. It's the current picture which makes us do that.
But actually, Sheila, what that happened? Because here, if you go just by the clinical presentations and everything, it comes in favor of a Meconium aspiration
Yes,
syndrome
yes.
and the subsequent complications. But somehow when we do a proactively, some of the investigation, we are actually
Land up in trouble.
Yes, yes.
So then you become, yes, if the child does not have a predictable course of action, depending on your interventions, then of course you have a second possibilities. Though it may slightly delay the diagnosis, or as the doctor from Chandigarh has already stated, if there is no actually predisposing factor like Meconium aspiration, of course, definitely you should evaluate the child, because they are coming very sick children coming in with coagulopathies, which are actually because of these MISN.
Prashant, agreed.
Yes,
What you
sir.
have commented, we also had more of right ventricular dysfunction and not so much of left. And the coronaries and others were not. That's why we were a little conservative here. And as narrated, we were seeing the standard response to our treatment of MAS. We did not pursue further with treating it as MISN.
But Dr. Vijay Lakshmi is very right. We come across the right presentation of MISN. And with the normal protocol, if they don't get improved, we go for MISN workup and they do land up with positive, as well as we need to treat them in some of the conditions. We have come across 3 hydrops also, whereas the hemolysis were totally unexplained. So that we have discussed with previous case also. So yes, MISN is still a mystery for us, and we all need to come up with the evidence and the studies.
Okay. I think we are
Thank you. Can go ahead.
running short of time. I think we should go ahead.
Yes. And the course doing NSU stay I'm continuing. Events on 3rd day of life, 60th hour of life, child is mechanical ventilatory support. Gradually we had came down on pressures of 16/5, F set of 40 and FiO2 25 with the vitals of heart rate 140, SpO2 97 on all 4 limbs, CFT was less than 3 seconds with normal NIBP. So clinically adrenaline tapered and omitted, and we had, after once the child was hemodynamically stable, we had introduced minimal enteral feeds after doing to repeat 2D echo, which was normal, and the ventricular function was restored. So, and at this time we have repeated one ABG. The pH was 7.39, PCO2 is 35, PO2 is 70, bicarb 19.5 with base excess 4.4. Saturation 95 and ABG with lactate of 1.77, which is normal. So we had gradually tapered on ventilator settings, and we had started introducing minimal enteral nutrition. And from 4th to 7th day of life, milderon also we were able to come down gradually. And for 24 hours, child was kept on HFNC with minimal oxygen support. And on 4th day of life, child was kept on full IG feeds with minimal O2 support. And then within next 24 hours, there was no tachypnea and distress noted. Child was maintaining saturation on intermittent O2 trial. So the baby was handed over to mother on 7th day of life on full KS feed, and child was kept in step down ward recovery room. And from day to 8th day, 10th events, the child was accepting full feeds, KS Katori spoon feeds, having episodes of fever, and then we had to repeat septic screen, which came out to be negative. And but the blood culture which was sent on first on receiving was suggestive of Acinetobacter sepsis. So sensitive antibiotics we were started, intravenous antibiotics, and with that the fever episodes decreased, and baby on breastfeeding started gaining weight. And so we had giving intravenous antibiotic according to culture sensitivity. Continuing the course during the KMC ward stay. In KMC wards, child was kept on for 11 to 22nd day. Child was on breastfeeding, kept on IV antibiotics, which was completed. And then we were able to discharge the child on 22nd day of life with consecutive 3 days of weight gain. After the neonatal screening has been completed, like OAE, both years has passed. Ultrasound head, which was done on 24 hours of life, which was normal, and at discharge also, it was normal, with the head circumference of 32.5, length of 51 centimeter, weight of 2.91 kg on 22nd day of life, with the birth weight of 2.9 kg.
2.5 to 2.9.
So the final diagnosis for this. Huh?
2.5 was
Birth weight, Janki?
2.5. It was not
2.5, ma'am. Yes,
2.5 birth weight.
yes,
Ah,
ma'am.
There is a
But
400 gram weight gain was there.
yes. So, the final diagnosis is it's a singleton full-term child, 39 week plus 3 days of gestation age, 2.5 kg, small for date, male child, vaginal delivery, and cried immediately after birth with severe meconium aspiration syndrome with respiratory failure requiring mechanical ventilation and surfactant administration. 2D echo is suggestive of PPHN with right ventricular dysfunction, and the MISN diagnosis has been kept as query because we had contradicting points for that. So with this, the
Yeah.
presentation is complete.
Why have you kept it as a small for? Go back to the slide. Yeah. Why did you keep it as a small 4-date baby?
39 weeker plus 3 gestation age child, sir.
But 2.5 kilograms.
Less than 10 centile on intergrowth 21st.
This is okay, no?
Because it is, I think 2.5 something plus comes just on the borderline of 10 centile.
Borderline.
And how 11th day an increase of, is it on the 11th day 2.9?
No, 22
22nd
day,
day.
day
On
22.
discharge. Day
22nd day of life.
On this side. Okay.
So that was later on, the child was on full feeds and gaining. 2.9 is on day 22.
Okay, fine.
Janaki, now last few question. What could be, if this parents want the prognosis to be explained, or you want to do a long-term follow-up, what are the things in which areas this child can have problems, or what would be your plan of follow-up for this child?
Child to be kept in high-risk clinic follow-up to look for the developmental assessment, ma'am. And initial screening, universal newborn screening was negative. Ultrasound height was also done, which was negative. With the follow-up, we have to look for the neurodevelopmental outcome of this child, as this child could have gone for hypoxic damage during the neonatal period. So
One is neurodevelopment. What is the other one? As far as pulmonary, what are the things which can come across in this child?
Chronic, long-term chronic lung disease can happen, like
what kind of chronic lung disease?
Like bronchial asthma incidence could increase in this child with Meconium aspiration.
Before that, in first year?
Bronchiolitis or allergic disorders, like.
Anything else? What the evidence suggests? Babies born out of severe meconium aspiration syndrome and who go through require a lot of ventilatory support. Maybe in first year of life, they are coming back with recurrent lower respiratory tract involvement, maybe a bronchiolitis, viral pneumonia, or recurrence with those kind of respiratory involvement is more likely. Your bronchial asthma thing would be too early to predict in the first year. That would be at a later date, but definitely incidence of getting lower respiratory tract involvement, viral or bacterial, and coming with frequent requirement of this is more in babies who have gone through such an illness.
Yeah, you have to basically advise and counsel the parents in regard to this, because they are prone to repeated infections also.
Yes.
Yeah. And moreover, but did you check the inflammatory markers? Did you review the inflammatory markers again?
No, sir, we haven't repeated the inflammatory.
See, the problem is you already shown that 2 or 3 of them were high.
Yes.
Whether actually you can send off a child with that report, though the child has shown clinical improvement.
Just the child has clinically improved with.
Agreed, it should have been done. Only thing is, because the CRP did not go up so much high, and culture treated antibiotics and child doing clinically well is where those
You are
markers
noted,
were
child
not.
So this child was gaining almost 40 to 60 gram weight gain per day before discharge. And so the most clinical parameter is the good weight gain of the child. We haven't subjected for the costly investigations.
See, but that has to be made a
Yes, sir.
note of it, you know.
Definitely.
Yes, yes,
Twice,
yes.
sir, the
Because
child
if
has
the
come for
child
the
comes
follow-up.
back with something or
Yes.
Yeah.
yes, should be.
Discharge and you see so much of there and nothing has been done. What was the cause? So when you do an investigation and it shows something which doesn't go in tandem with your diagnosis, or you do not act therapeutically, taking that investigation consideration, you
Okay,
have to either put a question mark or
okay.
put an explanatory note on the clinical ground that this is why
It
we
has
did
not
not
been.
take cognitions
True.
of the thing.
Okay, sir.
Yes.
Any
True,
third
true.
person who sees your
Regarding
discharge will
the
always
follow-up
ask a question.
the inflammatory markers, sir. So if we would have taken the possibility which is actually ruled out in this case and the baby didn't require any IV agent dexamethasone and improved,
Yeah.
so MISN diagnosis has been ruled out. So in such
Yes.
cases, the follow-up inflammatory markers is as such not required. If
Yeah.
at all the diagnosis of MISN had been confirmed, then we would have gone for a follow-up. And plus,
No,
as a diagnosis for MISN, if
no,
at
I
all the
totally agree with you on
positivity,
that.
it
Not
is
about
ruled out.
question about you're keeping a diagnosis, but I'm saying when you note any abnormal finding and you do not take a cognizance of that particular investigation from therapy point of view, you make your clinical notes very sound to share that we have not considered it in that manner. What you're trying to explain now.
Yes.
Yeah. I think because why
I
did
agree.
we get when it came abnormal? Okay, we ruled it out, but
Yeah.
then has it come down to
Yes, yes,
normalcy or
completely.
not? Would make it more, as well as documentation that it has not been done because of this. But one should keep in mind is yes, very well taken point. And I think medico-legally also it's necessary that we
Exactly. That's precisely
Yes,
what
yes.
I'm thinking.
Perfect.
Yeah, it's very well taken. Yes, it should be
Yes,
done. It should be.
Yeah. In fact, sir, now I am tempted with next follow-up, I should get it done.
Pardon?
Because the next follow baby is regularly coming to our Saturday DIC, that is HRC clinic.
Most of
So
these
we'll definitely
patients.
take this point into account. Thank
Yes.
you so much, sir.
Yeah. I think that should end our presentation, and we are, I think, on time.
Yeah.
Yes, most
And I
of the
think that
chat box
Dr.
questions
Janaki-
are done.
Answered during the discussion
Yes, yes.
itself. If there is still
Yes.
something left,
No, ma'am. I just there was
I
a
think
query
Prashant.
between sepsis and MISN, which you have answered. And as Uri ma'am has also said, that first follow the normal course. If the baby is not following the normal course and you are suspecting, then only you go for the MISN treatment part, or even for the sepsis also. So most of the questions are answered. Well presented, Dr. Janki. So the key messages, as he has posted,
Yes,
right from the intranatal care to resuscitation and then NICU care, if proper monitoring and protocol wise management is done, we can definitely, the nightmare what madam says, we can come out from that nightmare, that is MSL. And with the increasing gadgets and all that, we have really good monitoring system, ventilators, as well as the surfactant replacement therapy, and timely diagnosis of PPHN as well as MISN will give a positive outcome. However, there are certain mortalities and other comorbidities with such cases. Pulmonary leak, yes, we need to keep in mind that. So this is the key messages. Thank you so much. Thank you, sir, for accepting our
Thank you,
invitation
sir.
and being there. Once talked, I have never again reminded you nothing. You were there on time. That's really very good, sir. Thank you so much for giving your expert guidance to us. And Sheila ma'am, you're always there with us, as I said, 24/7, guiding us for each and every cases. Thank you for being part of this Neonatal Pathshala. Janki, you did a very good job.
Yes, ma'am. Thank
Now I
you.
would like to hand over to Prashant.
So I think it was a great discussion. I mean, first time we were having so many questions in the chat box. And luckily, I mean, ma'am and everybody was so vigilant that all the questions were answered and we finished in time. So this certificate is presented to Janakiram for presenting a PG case in Neonatal Pathshala. And we are
Thank you.
thankful to our chairperson, Dr. Shwetal for moderating it. And both are experts, Dr. Sheila ma'am and Dr. Sitaraman sir. So thank you so much for making it more interactive. And I hope the PGs have learned so many things. I mean, there were so many questions and answers. This time we are seeing many answers from PGs coming in chat box while the questions were asked from sir and ma'am.
Yeah.
So that is what is useful for the PGs. So thank you so much.
Good.
Thank you.
Thank you. Thank you all of you.